we are totally understand what is ablation. So yes, less invasive. But I will talk about a little bit of the IRE. So well, someone of you maybe didn't get used to it. So the IRE is a non-thermal ablation. So the advantage is so they use electrical power, which is a very high impedance between the needle to creating the nanocell in the pore, to creating the cell have a nanopore surrounding, and then they will break it. So after that, so our macrophage will catch it up. So mostly of the selling death is gonna be died by the apoptosis, which is gonna be there's no necrosis. There's quite like a good death of the cell. So that means the volume that can shrinkage a lot if we compare between the IRE and the other thermal ablation. So this is a very first evidence for the IRE how it's affected to the other connective tissue. So for the cell, it's gonna be dead for sure. But for the other connective tissue, which is surrounding by the fibrous tissue mostly, for example, there's something tubular like the urethra, the nerve, the bile duct. Most of them combine with the fibrous tissue, even the cell death, so they still remain the tubular function. So that's the reason why. So we can use the IRE in the cross or the very high risk area of the close to the bile duct, close to the urethra or the ureter. This is very beneficial of the IRE. So this graph showing you, so what is the IRE level? So actually if we put the electric voltage between them, so they have a zone, reversible or reversible, and you get it very high, we can create heat as well. So what we are talking about is this zone, in the blue zone. So which can create a cell death with the less of the thermal. So that means, so if we are putting a lot of the power, we can create the heat, like we have the electrical burn in the house as well. So be careful about this thing. So what about the prostate ablation evidence? So here this is a focal therapy as Dr. Wallet mentioned. So actually the focal therapy including we are doing only the target lesion, we can doing the hemi-ablation or doing the zonal ablation. So and this is quite a very first study of the IRE published in radiology from 2014 to 2017. They recruit the 30 men with a biopsy proven. So I would like to let you see the criteria that they choose the patient. So it's a low to intermediate risk of prostate cancer. The PSA is less than 15, PSA score is 3+4. So this is quite promising data or the patient that we should to select for focal therapy. So and what they got, so for sure the early phase of study is going to be the primary endpoint, and the secondary is going to be the biological or histological outcome. So, and the primary endpoint is very good like this. So, as Dr. Wallace said, we're not only treating the tumor, we want the quality of life of the patient as well. So the sexual function is very good. So it's 83% that still remain. So they have the leak-free or the pad-free content rate as well, which is very high comparing to the treatment by the surgery or even the SBRT. What about the biological outcome? For the PSA is reduced a lot. And yes, there is no residual cancer, but we can still find the recurrent in-field or out-field. So because sometimes the prostate cancer is a multiple lesion, it's not only the single one. So I will show you the case example that we already done in our center. So the 27 years old male with a prostate cancer, they was already treated. So at the starting point, so maybe this is not a good candidate for the beginner like us, but anyway, because the patient failed off the SBRT, so our radiation oncologist need to find the other choice for the patient. So they send the patient to us. The patient underwent the SBRT on 2021, and this is the PSA level. So it's increased a little bit from 0.3 to the 2.2. So and this is the MRI imaging of the patient. So we can see the resting diffusion here, the low signal on the T2 like this, and this is a tumor that we already proved by the biopsy, by the MRI fusion, and the results turned out to be the adenocarcinoma. So before we start to doing that, the procedure needs the patient preparation a little bit. So I do prefer, even we are not doing by the transrectal, but I think so giving the laxative drug for the patient is going to be better for us. So we give the laxative drug for 2 days, giving the prophylaxis antibiotics, cephalosporin. And for sure, during the IRE, we need a general anesthesia with a deep muscle relaxant. I will show you the picture of the position, and we use the MRI transrectal ultrasound fusion with the grid, which is like a needle holder, and we can just insert the needle along the grid. Okay, so and I retain the folate catheter as well. This is the video from the angiodynamic. Maybe you can see very easier to demonstrate how the IE performs. This is a lithotomy, this is a grid that I mentioned. So why we need a grid? Because during the procedure, so the IE need at least 2 needles. So, and we also have to hold the ultrasound probe as well. So the grid is helping you holding all the things. So otherwise you need a very multiple hand from the assistant. So that doesn't work. So we need a grid. We need a transrectal probe, and it's easy to puncture. Don't forget the IIE needs the parallelity, right? The needle need exactly parallel. So using the grid is make us very more easier to get the parallel. So this is our room. Though we still doing the IRE prostate in the axial suite. If you notice, this is our single arm here, and just shift. Yeah, this is a table from the Philips. So we just borrow this kind of thing, the lithotomy one from the urologist, and just stick it up into this table. So, and this is what we are set up. So we use our huge monitor in front of us, and this is the ultrasound machine with the fusions. So here, this is a patient on the lithotomy. So you have to learn a little bit about the lithotomy position. I'm sure you are all forgot how to create a proper lithotomy position before doing this procedure. And me too, we need to call him every time. So just help me a little bit. Okay, and this is how we do a transrectal approach for the ultrasound, and this is a real one, the template bit is just above into this instrument for the needle holding. So and this is what we are look like. We have the monitor here, which is the same monitor. So and this is our target. So and we're gonna see this is the simulate of the point of the whole of the grid that we have, and this is one needle, and this is the second needle. So in this case, we use the 3 needle, 1, 2, 3, far apart 1.5 or 2 centimeters. So and then we emit the energy, and this is what the result, the current respond back to us like this, and this is the outcome of the ablation in this case. So you will feel surprised. So this is what we are creating, exactly the same as we're planning on the IRE machine, right? So we create almost the hemi-ablation. And if you are a very good eye, you can see they have the artifact, dot artifact black one. So this is the gold that the patient already have the SBRT up. And they put the gold marker, which is on the IFU, so the IIE should not be done in the field of the metallic, but because the patient have no choice, so we have to done it. And I think this should be the real goal. So they should not induce a lot of or deviate our field of electromagnetic, and which is proof that we are create very perfectly of the ablation zone, even the patient had to go inside. So this is our outcome for the 3-month follow-up MRI, and this is so nice. And this is 3-month follow-up in a static image here. It's really surprised that we get a very good outcome. So this is the second case, the 70 years old male. Again, performed twice of the SBRT, and the PSA level is increased. Actually, this is my very first case. So and actually, it's very more difficult than the others. So and here, this is a truthful sign of the suspected the recurrence of the prostate cancer. So one of the very difficult in this case because the patient underwent twice of the SBRT, make a prostate gland is very small. So the diameter of prostate gland is only 2 centimeters. So and we need to avoid the urethra as well. So at that time, but because of first case, I cannot reject Dr. Varat, right? So otherwise I cannot have a case. So I will say yes, okay. So I try my best. So and this is a lesion, the first lesion. And so here, we decided to do both of the lesion at the same time, and we also do the biopsy at the same time as well. So and this is what we are doing, but we are as we see. So because the lesion is very small and the prostate gland is very small, so we're using only 2 needles to create a ablation zone. In 1 week after procedure, the patient got a prostatitis, and this guy is very concerned about the sexual function. He tell me about, so after SBRT, he feel like a 50% reduction of the sexual function. And after the IRE, he said, it's reduced a little bit of the 10%. Yeah, I think, okay, yeah, I think we are doing very good. So because comparing the 50% reduction and the 10% reduction. But what we have the PSA level is quite promising, right? It's from 3.8 to the 0.3. And yeah, this is a PSA level. This is from on 3 months, and this is from on 9 months.